Hi, everyone. Welcome back to our Monty Hart lecture series. It's a pleasure today to have Dr. Lilia Sierra-Galan from Mexico. Dr. Sierra did all her training in Mexico for cardiology, and then she performed training in CMR in particular and NIH, and then went ahead to perform further training on CT with Dr. Carlos Rochit in Brazil. She after that went back to Mexico, and she has become, I think, probably one of the top in the world in the CMR imaging for autoimmune diseases. I think a topic that is usually not covered, but very hard and very important for all of us. So we're very excited about your lecture, and thank you very much for joining us, Dr. Sierra.
Thank you. Thank you very much for the invitation. I'm very honored, really honored to be here. So let's talk about a bit about autoimmune diseases. The first thing I want to highlight is the broad spectrum of diseases that we have. Really, it is really a very complex area, and the way we decided to do this was with the collaboration with a rheumatologist, Dr. Soto, who helped us to do this classification. So we divide the diseases in rheumatology in systemic, localized, secondary to hypersensitivity, of unknown etiology, genetic, and other. And from systemic, we have with autoantibodies, and the main ones are obviously lupus, antiphospholipid syndrome, systemic sclerosis, polymyositis and dermatomyositis, Sjogren's syndrome, and rheumatoid arthritis. Then we have other different type of diseases that we are not going to review here. And from the unknown etiology, it could be with or without autoantibodies. And from there, we have the most broad diseases, which are the spondyloarthritis, which involves a lot of different type of diseases, still disease, and other osteoarthropathies, and all the vasculitis, where you can see there is a lot of different type of diseases. Then we have others, the genetics ones, and others that include also the oncological ones, the metabolic, the infectious, and other different type of diseases. So it is a very large spectrum, and very difficult to cover just in one talk. So let's go for the first one, which is the systemic ones with autoantibodies. And from them, we are going to start with the lupus. Lupus has involved in cardiovascular diseases to pericardium. And usually it is just pericardial effusion, but rarely could end up in tamponade, in cardiac tamponade. Then is the valvular heart disease that everyone knows and recognizes, the Liebman-Sachs endocarditis. And not only the Liebman-Sachs endocarditis, but also the valve thickening, where it is the most important or the most frequent abnormality, more frequent than Liebman-Sachs endocarditis. And then the other forms of valve dysfunctions, where the most frequent one is the mitral regurgitation. It could be also mitral stenosis, tricuspid, and aortic regurgitation. So we have to have those in mind. And those valvular heart disease are used to be linked to higher titers of antiphospholipid antibodies. So this is overlapping with the antiphospholipid syndrome. Then the next part of the disease is the coronary artery disease and the myocardial infarction. Why these patients are having the coronary artery disease and the myocardial infarction is for different mechanisms. It's not from atherosclerosis. We are going to see an example of that, a very dramatic one. And the reason or the pathophysiological mechanisms are the endothelial dysfunction and the arterial thrombosis. So with those mechanisms, in addition to the atherosclerosis that every patient, even with the autoimmune disease, could have, are the leading causes of cardiovascular morbidity and very important factors for the development of heart failure. The other one is the treatment. The treatment itself could cause a cardiovascular disease in those patients related to the use of prednisone and hydroxychloroquine. Those dependent, its cardiotoxicity is dose dependent, and they produce restrictive cardiomyopathy. So in this spectrum, we already have different type of involvement of the heart. The other one is the primary myocarditis. This is another very important problem that the lupus patients has, and it is a very complicated mechanism. And finally, the inflammation of other sites within the thorax, which is the inflammation of the pleura, pleuritis or pleurisy, and it could have at least minor or trivial pleural effusion. So what is CMR offering to lupus? Well, based on those mechanisms of the disease, we could evaluate the valvular heart disease, where we are going to assess the hemodynamic significance with different sequences. We are going to use CINE. It could be SSFP or CINE fast gradient echo, could be phase contrast, or even 4D flow. We are going to evaluate the pericardial involvement, where we are going to see the identification, the assessment of hemodynamic significance, the detection of inflammation, and we are be able to differentiate the presence or not of constriction. The sequences are CINE, it could be SFFP, free breathing real-time CINE for the constrictive pathophysiology, and we are going to use the newer mapping techniques or the morphological sequences, the T1 and T2 stir images, and also obviously the LGE sequences. For right and left ventricular dysfunction, well, CMR is the gold standard, and we are going to use CINE SFFP, or we can go further and use strain and diffusion tensor. Then for the identification of myocarditis, we are going to use T2 weighted with the steer, all the newer mapping techniques in T1, T2, and the extracellular volume, and obviously the presence and characteristics of LGE. And then the vascular involvement, we could see the coronary arteries, the thrombosis, the vasospasm. Obviously, this is better done with CT, but it is possible to do it with CMR. And we are going to see the involvement of great vessels, such as the aorta or the pulmonary arteries. And we are going to be able to identify the microvascular dysfunction, which is another mechanisms of the endothelial dysfunction and the cause of heart failure, as I mentioned it before. And the sequences, again, are the CNF-FSP or fast gradient echo for the flow, or the MR angiography, stress first pass perfusion, or even though again the LGE. So I am not going to use CNIS this time, because it is a very large talk and confusing. So I am going to focus just in the findings. And here, first, as I mentioned before, we are going to evaluate the valvular heart disease, which in lupus is very important. See how very tiny findings could be seen if we read carefully these cases. So, for example, here we have a Liebman-Sachs endocarditis, which was confirmed by a biopsy. Then the valvular thickening, as we mentioned before, or the valvular dysfunction, in this case is tricuspid regurgitation. So those findings are very common, and we have to be aware of that and look for those. Okay, next is the RV and the LV dysfunction. For those evaluations, obviously we all know that CMR is the gold standard, as it was proven long ago, since 2000. Many publications have demonstrated the importance and relevance of this, and even that its high reproducibility that allow us to use a smaller sample size for a clinical trial. So we don't need to discuss more about the function, but it is the gold standard. So for myocarditis, we are going to see the traditional findings, such as in the T2 STEER weighted image, we are going to see the increased signal intensity, or in the T2 mapping, we are going to find an increase in this signal as well. The values are going to be increased, or even in the native T1 is going to be higher. Then we are going to have the typical findings of myocarditis, but those are more subtle than the regular myocarditis. So we need to look for those. And if you see carefully, you are going to see this mid-wall LGE and in different sites. We are going to see the increased signal intensity in the valve. And with that, we can consider that maybe there is a component of inflammation there too. And for the perfusion, we're going to see here the typical subendocardial ring perfusion defect that is consistent with microvascular dysfunction. So there is a lot of findings, and we can go further of that and see the vascular involvement, or not only as a perfusion defect, but for example, in this case, we had the presence of atrial fibrosis, and this patient arrived to the emergency department with a rapid atrial fibrillation that required cardioversion. And CMR showed that she, a 30-year-old woman, apparently healthy woman, had that fibrosis in the atria. So that give us a lot of information and orientation to further treatment, and see how she also had the pleural effusion. So all the pathophysiological mechanisms I mentioned are there, okay? This is another example, which is even more dramatic. see how the first visit to the emergency department was because of a complete occlusion of the LID, and she was treated because no one knew at that time that she had lupus. This patient arrived to the emergency department with this acute myocardial infarction, and she was treated as an atherosclerotic patient. But 2 months later, with the proper treatment and the stent placed and all the medical treatment optimized for the coronary artery disease, thinking in an atherosclerosis substrate, she developed a second event, and see what happened in the second event. The second event is terrible, because you can see here this huge left ventricular aneurysm, and she was prepared to surgery, but we truly kidnapped the patient to the scanner and saw what happened there, because the ultrasound guys, the echocardiographers, said that this patient had a pseudoaneurysm, but we were not confident with that diagnosis. So we took the patient to the CMR scanner, and then we found that the patient had a true ventricular aneurysm with a large pericardial effusion and some characteristics that were like a inflammatory pericardium, which is not consistent with an atherosclerotic patient. So this patient had something else, something different, and two different type of thrombus, one old, one fresh. And then we decided to accompany the patient to the operating room, and it was a true aneurysm, as we can see here. And the thrombus has these two components, one old, one fresh, as was confirmed by the pathologist. But the interesting thing is that we took fluid from the pericardium and from the blood, and in both we found two different patterns of anti-nuclear antibiotics, and that confirms the presence of lupus. So the patient started with proper treatment of lupus instead of the treatment of atherosclerosis, and she went better, and she never had another event. So that highlights the importance of the proper diagnosis. So as I briefly mentioned, we can find the pericardial effusion and the pericardial inflammation, which changed completely the finding and the diagnosis. So it is very important to investigate all these different characteristics, and to always have in mind that not everything is atherosclerosis. And with that thing, we could evaluate all the parameters that we mentioned in the table. So let's go for the next one. The next one is going to be antiphospholipid syndrome. And for the antiphospholipid syndrome, we are going to see the different pathophysiology and all the components of the disease. Again, the valvular heart disease with the Liebman-Sachs endocarditis, you see that is not unique for one pathology. It could be present in different ones. Then the valve dysfunction again, and a very typical finding, which is the intracardiac thrombosis. The intracardiac thrombosis could also embolize to the brain, and sometimes is often its initial manifestation. So frequently the initial manifestation is a stroke, and then the autoimmune disease is diagnosis is done. So the next one is the thrombus in other sites. The problem with the antiphospholipid syndrome is the presence of thrombosis in almost everywhere. It could be venous or arterial. And in the lungs, it affects the large vessel, and it could produce microvascular thrombosis. And with this chronic process and with the presence of these antibodies and the inflammatory process all the time, there is endothelial remodeling. So that causes pulmonary hypertension and also right ventricular dysfunction. With this, the main mechanism is inflammation, but also we had vasculitis, myocarditis, and vascular stiffening. And with those, we ended up in a very high pulmonary hypertension and obviously with right ventricular dysfunction. But also we have left ventricular dysfunction. And the left ventricular dysfunction is due to arterial thrombosis again. So we are going to have problems with the coronary circulation. We are going to have, again, microvascular dysfunction. And also we are going to have microinfarction and small scars with fibrosis. So those, in addition to the myocardial edema, is going to produce systolic dysfunction. But the systolic dysfunction, even is if it's caused by myocardial edema and fibrosis, is not related to atherosclerosis, is related to the arterial thrombosis and the microvascular dysfunction. So these patients end up in dilated cardiomyopathy. So it is very frequent to have these patients with dilated cardiomyopathy, and the patients that do this the most are those with high titers of IgM antibodies. So then ischemic heart disease, the other one was not properly ischemic heart disease. It was the microvascular dysfunction and the thrombosis, but now we are going to talk about exactly the ischemic heart disease, where again, the microvascular dysfunction and the arterial thrombosis has a role, but also the myocarditis. So we are going to have also a myocardial infarction, but in this case, it's going to be a large myocardial infarction. It's not a small myocardial infarction. So the mechanisms are interacting all of them together, and additionally we are going to have coronary vasospasm. So all of those are going to produce large infarctions as the atherosclerotic disease could produce. So this myocardial infarction could be the first clinical manifestation, and we can confuse the diagnosis and make a wrong diagnosis and treat the patients not the best way. So it is very important to identify the pathophysiology. Then we are going to have thrombosis, as I mentioned, in the arterial and venous systems at different levels. And what are we going to find by using CMR? All of those. We are going to see the valvular heart disease with the Liebman-Sachs endocarditis, where we are going to evaluate again the assessment of the hemodynamical significance. And since it is very reproducible, we can use this technique for follow-up. Then we are going to have intracardiac thrombosis, which, this method has a high resolution, allows the location, the tissue characterization, as in the case I showed you before, and allow to assess the hemodynamical significance. And again, it is reproducible, so it's very useful for follow-up and is radiation-free. For pulmonary hypertension, it allows to evaluate the severity of the hemodynamic significance of the pulmonary hypertension, and could orient to the potential etiology. Then the right and left ventricular dysfunction, again, is the gold standard. We can see easy the myocardial edema with the T2 steer sequences, or even with the T1 and T2 mapping, or the extracellular volume. And we can see the myocardial ischemia for the large epicardial vessels with the stress perfusion, or both for the microvascular dysfunction. And the myocardial infarction, we can see everything, if it's a focal or diffuse scar or a diffuse fibrosis, of if we have endomyocardial fibrosis. So a case with antiphospholipid syndrome, it is like this one. So first, again, the assessments of the valves. See, it is very tiny, or the findings are very tiny. So we really need to be careful when we read these cases, and see how small could be the finding, like this one, or the thickening of the valve. But those are contributing with diagnosis. Then again, the right and left ventricular dysfunction, the myocardial edema. In this case, we don't have the mapping available, but the mapping would add the diagnosis. And the myocardial ischemia for the large epicardial arteries, or for the microvascular dysfunction, as is in this case. And the presence of fibrosis with different patterns for ischemic or non-ischemic etiology. And additional findings are these ones, the thrombosis in different sites. So with the same scan, for example, this image is just the localizer, and here we have the thrombus of the portal vein. And here, if we see here, when we can give the patient additional free slices from the liver, and see how we see the thrombus here and here, and see that this is the cause of the problem. This patient was already sent to the liver transplant protocol, and it turns out that he didn't need the liver transplant. He needs a different treatment because he ignored that his problem was an antiphospholipid syndrome instead of a liver disease of unknown etiology. So this changed the diagnosis, the treatment, and the prognosis of the patient. So it is very important to do that. Then we are going to talk about rheumatoid arthritis. And with the rheumatoid arthritis, we are going to have a very large spectrum of diseases, or the mechanisms. We're going to have again, the valvular heart disease, where in this case, we're going to have valvular thickening, and we could have stenosis. So maybe some of those patients that we call it a degenerative aortic stenosis, maybe it's not, and maybe is related to the rheumatoid arthritis. Then the pericardium, it could be pericardial effusion or pericarditis, and we're going to have conduction system problems with rhythm disturbances. It could be atrial or ventricular, and also the lung. We are going to have a pulmonary fibrosis and the pleura, pleural inflammation or effusion. Then the myocardial damage. These patients characteristically have left ventricular hypertrophy, which is interestingly the earliest cardiovascular involvement finding. And again, we are going to have microvascular dysfunction, myocardial ischemia, myocardial fibrosis, myocarditis again, and all of those are going to produce dilated cardiomyopathy, and also the rheumatoid arthritis will produce problems in the aorta. We are going to have loss of compliance and an aortic stiffness with all the consequences of that problems. And finally, heart failure. So we are going to pass from all the stages of heart failure, systolic, diastolic, and congestive heart failure. And sadly, the incidence of congestive heart failure is approximately 2-fold higher than in general population. So we need to be clear of that. We need to be very aware of these diseases and all the problems that could cause, because the rheumatologists are not aware of this and the cardiologists are not aware of this. So it is a very important research area. The pulmonary hypertension and the right-sided heart failure is a consequence of all those findings that all those mechanisms that I just mentioned, and this increases a lot the risk of these patients. So what has CMR to offer in this disease? Again, the measure of ventricular function, the presence of myocarditis, the presence of fibrosis, all the evaluation of heart failure, and the most important thing, to orient to other etiologies or to discard the other causes of heart failure, and with its reproducibility, the feasibility of having a good follow-up free of radiation, very reproducible, and to have prognostic information. And with the vascular involvement, because we are going to be able to see not just with the MRA, but even with the characteristics of the vessels. Okay, so in this case, you know that left ventricular dysfunction, right ventricular dysfunction, myocarditis with the T2 steer and all the mapping techniques, and the LGE. They identify the myocardial fibrosis, and you have the prognostic information of it, and the vascular involvement. As is in this case, we can see how there is a pulmonary artery enlarged, which has also compromised already the right ventricle. And we see how is hyperintense the aortic wall. So these patients also have aortitis. So we can see different things, as I mentioned before, the valve thickening and extra cardiac findings, as is in this case. We see this mass, this granular tissue, which could be found in rheumatoid arthritis as well. Then let's talk about systemic sclerosis. I think that systemic sclerosis is the disease of this group that has been most or broadly studied, and is the one that almost everyone recognizes that it has cardiovascular involvement, because it is reported in up to 75 to 80% of the patients. So what produces the systemic sclerosis in the cardiovascular system is in the lungs. It produces a non-specific interstitial pneumonitis, which passes from the inflammatory phase to the fibrotic phase, then interstitial pneumonia, and finally pulmonary hypertension, and obviously the consequences in the right heart. The more fibrotic, the less, this disease is more fibrotic and less inflammatory. That is a different to the pulmonary hypertension that we see in the rheumatoid arthritis. Then the pericardium. The pericardium is due to pericardial inflammation. First, we have pericarditis, which affects 10 to 20% of the patients. Pericardial effusion, that usually produces a progressive thickening, which can end up in constrictive pericarditis. And you know that CMR is very good to differentiate the constrictive versus restrictive physiology by using free breathing real-time sequences. Then the myocardium will show a myocardial edema using the T2 steer sequences or the T2 mapping. Then the myocarditis with all the Lake-Lewis criteria. But the interesting thing in the systemic sclerosis is that the myocarditis could be fulminant. So it is very important to identify this cardiovascular involvement very early in the process. And this affects 38 to 56% of the cases. And sometimes this myocarditis, when it's not fulminant, produces myocardial fibrosis. And this myocardial fibrosis, well, is going to affect the ventricular function, but also is going to produce other problems, and characteristically affects both ventricles, left and right ventricle. So we need to look for both. And this progresses and produces conduction disturbances. So we are going to have different type of conduction disturbances: atrial from the union, or from the bundle or its branches, or even within the ventricles. So it is a risk for lethal arrhythmias. And then the vasculopathy. For the vasculopathy, the lungs are affected. As I mentioned before, this disease is more fibrotic and less inflammatory, but in the lungs is going to produce fixed lung resistances. In the coronary circulation is the same, is more fibrotic, less inflammatory, and it's going to produce a chronic vasculopathy similar to the Raynaud phenomenon. So these patients have a chronic chest pain and perfusion defects, which at the end are going to produce microvascular infarction, small scars with fibrosis, and obviously with the inflammatory component is going to have a very bad evolution. And in those patients that are positive to anti-topoisomerase 1, are more prompt to have this kind of vasculitis or vasculopathy. Then the heart as a whole structure has the dilated cardiomyopathy again, and it will end up as a systolic and diastolic heart failure. So what are we going to find in this systemic sclerosis? Well, again, the myocarditis, the pericarditis, and the possibility to differentiate between the constriction or the just pericarditis or the presence of restriction, the pulmonary hypertension, and the function. So maybe the findings are not too impressive, but are consistent with the information. So again, we have all those data of myocarditis, then the pericarditis, and the such as this inflammation in this area of the pericardium, which is if this process is chronic, then we are going to have some constriction, and the function, obviously. And other cases, again, we are going to see the function, then the presence of a diffuse edema, and since these patients have small infractions, as I mentioned before, we could see these small infractions without any specific coronary distribution, which is highly suspicious of these kind of diseases. And chronic inflammation shows in the higher T1 native values. And see how this patient, for example, has the evolution in different periods of time. So first, the patient has the diagnosis. No? See how the patient has low ejection fraction, around 4%, and is in atrial fibrillation. As I mentioned before, this disease causes atrial arrhythmias, and one of the most frequent and important is atrial fibrillation. Then there is more fibrosis than inflammation, remember that, so it's not that impressive, the myocardial edema. They have infarct with the coronary distribution or with no coronary distribution. They have pericarditis and obviously the pericardium effusion, but the pericarditis is inflammatory, and the T1 is higher, so mainly in some patches areas, and the extra cellular volume is increased. And if the patient does not receive the proper treatment or complete treatment, maybe it's going to improve in some components. For example, this patient received some treatment with prednisone and mycophenolate, and with this, the function improved. The edema didn't change because since the beginning it wasn't the main problem. The infarction, every chronic infarction shrinks. But the problem of a pericardium increases because we are not treating the inflammatory pericarditis. So the pericardial effusion increases and the inflammatory process increases. And we need to add colchicine to treat the pericardium and see how the patient improves. Now it's in sinus rhythm with a pretty normal or almost normal ejection fraction. And the T2 value is almost the same because, as I mentioned before, is more fibrotic than inflammatory, and the infarct size remain similar, and the pericarditis is still active, but see how the pericardial effusion reduces, and the amount of inflammation is maybe a little bit less. So that highlights the importance of the diagnosis and the role of CMR. Then we are going to talk about adult onset STL disease, and adult onset STL disease mainly affects serous layers, such as the pericardium. Again, pericarditis with 30% of affection for these kind of patients. Here, if the patient has high blood cell count, polymorphonuclear cell counts, or higher serum ferritin levels, it is even worse, and the patient has more pericarditis and more pericardial effusion. And this could evolve to cardiac tamponade. This is the disease that mostly affect the pericardium and could evolve to cardiac tamponade. The others are very rare. This is rare, but the others are very rare. And in terms of the heart, we are going to have endocarditis again, which affects 7% of the cases, myocarditis, which is the most frequent finding, which is 54% of the cases. In this disease, myocarditis presents very early in the evolution. So if we don't have a high degree of suspicion, we are not going to see this very early, since 90% of the times is asymptomatic. And with these findings, the patient evolves to left ventricular dysfunction with usually left ventricular ejection fraction less than 50% in 67% of the cases. And it could evolve to cardiogenic shock and to arrhythmias. Which ones? Atrial fibrillation and ventricular potentially lethal arrhythmias. And 42% is the second cause of death in this group of patients in the acute event, and 21% at a year. So CMR should be part of the investigation in these cases. Then they have coronary artery disease with non-specific ST segment and T wave abnormalities. as this example. So we need to have a high degree of suspicion, again, because that presents in 79% of cases. What can do CMR for these cases? LV dysfunction evaluation, myocarditis, pericarditis with the ability to identify the tamponade. And for the next one, which is the polymyocytes and the dermatomyocytes, this affects mainly the valvular heart disease, again, by thickening the valve and producing valve dysfunction. Which valves? Only the left one. It could be aorta or it could be a mitral valve. Both produces stenosis. So again, not every mitral stenosis is rheumatic, and not every tri-valve aortic stenosis is degenerative. It could be polymyocytes or dermatomyositis. The most affected is aorta with 46.7% and mitral valve with 20%. So this could be the primary manifestation in almost 7% of the cases. The conduction system is also affected, and it is by an infiltration due to the the lymphocytes in the conduction system and the fibrosis of the sinoatrial node. And this could produce left bundle branch block, right bundle branch block in 33 to 72% of the cases, but also could have supraventricular tachycardias, PVCs, ventricular arrhythmias such as VT or AFib. And those cases who has AFib has 12 to 50% of those that develops myocarditis. So if we see a patient with this disease and has AFib, we should do a CMR because it is highly probable that this patient has myocarditis. Then they frequently have a left ventricular hypertrophy. So if these patients also have blood hypertension, we need to do CMR because we are not going to be able to differentiate the cause of that hypertrophy. Then myocarditis is going to be present in 8% of cases. Remember, if there is AFib, it's going to be more often. Then left ventricular systolic and diastolic dysfunction, and that is in 32 to 77% of the cases. Myocardial ischemia and coronary artery disease are very interesting here because they have the progression of the atherosclerosis itself. It is more rapid than in regular population, and they have increased risk to plaque rupture or erosion. So if the patient have a plaque erosion, well, we are going to have an acute coronary syndrome, and if the patient have a progressive atherosclerosis, probably we are going to end up in a myocardial ischemia or even in a myocardial infarction. And with the rupture, we are going to have an acute coronary syndrome, maybe myocardial infarction. And the other mechanism is because we already have a left ventricular dysfunction that increases ventricular filling pressure, and that will produce as well myocardial ischemia. The pericardium affects with producing pericarditis in 4 to 25% of the cases, and is usually asymptomatic and hemodynamically insignificant. But if we have 3 antibodies present or positive, which is the anti-YO, the anti-MI, or the anti-SRP, we are going to have an anti-synthetase syndrome. This is immune-mediated necrotizing myopathy variant, and that produces 50% of pericarditis and produces also tamponade. And they also have pulmonary hypertension and right ventricular heart failure. And it is more common in that syndrome where those antibodies are positive with the antisynthetase syndrome, and is present in 8% of the cases. What is CMR showing in this case? The valvular disease, the pulmonary hypertension, the myocardial edema, the myocarditis, the myocardial inflammation, the right ventricular dysfunction, and the left ventricular dysfunction. And as it is showing here, it could be probably not that impressive, but the findings are there. So we have the ventricular dysfunction, the signal intensity increase in the T2-steer sequence. Obviously, in the T2 mapping, we are going to have a higher value of native T2. The subepicardial pattern of LGE and the increased native T1 value. And now we are going to talk about eosinophilic granulomatosis with polyangiitis, which previously was called Churg-Strauss syndrome. Everyone knows this disease as Churg-Strauss syndrome, but officially now it's called eosinophilic granulomatosis with polyangiitis. And this disease has a heart involvement in 50 to 60% of the cases, mainly in those cases that are antibody negative, is ANCA negative. So be careful with that. And 40% remain asymptomatic. So again, we have to have a high grade of suspicion. And those patients with ANCA negative and asymptomatic are those who has poor prognosis and are responsible of 50% of death of this disease. So what happened with this disease? Well, in 73% of patients, we are going to have valvular heart disease. Which valves? Only aortic and mitral valves, but to a mild degree. So we are going to have some mechanisms that produces this. Is the necrotizing granulomatosis inflammation, the eosinophils infiltrating the valve leaflets, the leaflet thickening due to the fibrosis, and for the aortic valve, an intense inflammatory reaction, but for the mitral valve, also, in addition to the intense inflammatory reaction, the endocardial fibrosis involving the papillary muscles. And the myocarditis, which could be the first and the most severe manifestation. In 59% of the cases, mostly are younger ages and mostly are males, where it is also the worst prognosis. So we really need to look for this. And the myocarditis is even worse if we have a higher than 20% of white blood cells count of eosinophils. Those cases are, those patients are those who has infiltrates the myocardium, or these eosinophils infiltrates the myocardium. What are the specific cardiac characteristics of this myocarditis? Is reduced global systolic function with diffuse LV hypokinesia, increased wall thickness and total LV mass, marked myocardial edema, and diffuse subendocardial eosinophilic infiltrate. And again, these associate with ANCA negative status. The pericardium is the more is very frequent and is affecting 41% of the cases with who has cardiac involvement. It could be pericarditis, it could be pericardial effusion, it could be tamponade, or it could produce intrapericardial thrombosis also. And these also have intracavitary thrombosis. This intracavitary thrombosis is different from the other one we saw previously with the antiphospholipid syndrome, because in this case it's subendocardial eosinophilic infiltration in segments with wall motion abnormality. So it is not just the clot, it's the clot with eosinophilic infiltration of the subendocardium, but in the segment that has a wall motion abnormalities, because that myocardium is also infiltrated. And could be localized or massive, and could be could involve single or both ventricles, and can embolize the brain and be the origin of the stroke. It also affects the conduction system, and it is very frequent at different levels. It is usually asymptomatic and rarely is life-threatening. But which are the possible mechanisms? It could be myocardial ischemia secondary to necrosizing vasculitis of a small and medium-sized arteries, or it could be infiltration of the myocardium and the His-Purkinje system. And those are the leading cause of sudden death in these patients. So we really need to be aware. And heart failure is not the most impressive problem. It's only 4% of the cases, and those has systolic and diastolic dysfunction. But in those cases, just the diastolic and systolic dysfunction could be in 50% of the cases, but heart failure is only in 4% of the cases. What are the causes of that heart failure? Is myocardial edema, fibrosis, eosinophilic myocardial infiltration, and it could coexist with epicardial coronary vasculitis, and obviously producing myocardial infarctions. And the right ventricular dysfunction, which accompanying the left ventricular dysfunction when it's prominent, could be isolated, but it is really unusual. And it could have the typical tri-layer appearance of the thrombus, the typical V of this disease. These patients that has a heart failure has the poor prognosis and could be the cause of death. So we need to be aware that this heart failure could be, in some cases, reversible, but only when the diagnosis is made early and the proper treatment is received. So CMR should be done early in the process or the diagnosis of eosinophilic granulomatosis with polyangiitis. And there is less recovery and worse prognosis when the heart failure is due to myocarditis. The coronary arteries are also affected because it's a vasculitis, and the pathophysiological mechanisms is myocardial ischemia due to the sudden severe reversible vasoconstriction of a normal or diseased epicardial coronary artery. Is due to vasospasm because of the eosinophilic infiltration of the coronary artery wall that directly stimulate vascular smooth muscle contraction and adventitial nerve fibers by their proteins or vasoactive cytokines, and by direct damage to the vascular tissue that predisposed these arteries to dilatation, aneurysm formation with higher propensity to dissection, thrombus formation, fibrosis of the intima and medial layers of the vessel wall. And it often arthritis, and it is rare that it is due to vasospasm. And these patients have a higher risk of recurrent coronary event, despite the medical treatment for conventional atherosclerotic coronary vasospasm. So the diagnosis needs to be done because they need to be treated as a rheumatological problem, not just as a atherosclerotic problem. What is offering CMR for these patients? Again, myocarditis, pericarditis, arrhythmias, valvular heart disease, intracoronary thrombosis, coronary arteries, vasculitis, or the inflammation, LV and RV dysfunction, the causes and prognosis of heart failure, the assessment of coronary vasospasm and if it's producing myocardial ischemia, and we could see also the peripheral venous thrombosis. So a nice example is like this one, which has the left ventricular hypertrophy, and the left ventricular function is normal. The T2 mapping is higher, is in the range of 60 to 65 milliseconds. LG is positive and with a diffuse and very confusing pattern. We need to be sure that we are properly knowing the myocardium because it could be confused, and we need to read it carefully because it can confuse with amyloidosis, and the extracellular volume is increased. The native T1 is not that high as in amyloidosis. So what is a CMR offering to these pathologists that other methodologies cannot offer. So if we see all these pathophysiological mechanisms, we are going to see that we have electrocardiogram, the chest X-ray, CT, echo, CMR, and nuclear. I am not going to go into details of each of these because it's going to take forever, but we can see this. See, see all the non-highlighted concepts, the technique that has more options available and it is good for that options is CMR. The others has limitations. CMR obviously has limitations, but it has more too often than the other methods. So it is a very good methodology for this type of diseases that should be implemented in the routine. So what are the limitations of CMR? Well, it's low availability, it's not everywhere. We are working on that. CMR is contraindicated, you know, in some cases. Every day is less contraindicated. The gadolinium-based contrast agents and the renal function, but recently it is not that such a big problem with the newer agents, and there are no cost effectiveness analysis from of a CMR in this specific group of patients. So that limits the broad application of this technique. So the key points of this talk would be to use this technology or this imaging modality in these diseases as I just review in detail. The proposed CMR protocol, well, is something that we already discussed in detail as well. And here is an algorithm that it is published in the AICBI consensus, where we wrote this algorithm and we said, okay, if we have a patient with an autoimmune disease that fits this group of diseases, is it newly diagnosed? Yes, then go straight to CMR. If it's no, the patient had cardiac symptoms. If not, well, clinical follow-up, and 1 year we will reevaluate. Then if the patient has cardiac symptoms, then do the routine. And if it's abnormal, then if that is abnormal, then we should initiate the proper therapy and do CMR. If it's abnormal, do CMR. If we want to follow up the treatment or follow the patient of give prognosis, do CMR. If we consider that the other evaluations are not so precise, then go to CMR. And if there's a mismatch in the symptom severity and the findings of the other technology or the other imaging modalities, then go to CMR, okay? So the clinical applications would be early identification of asymptomatic patients with cardiovascular disease in this group, the elucidation of the cardiovascular disease acuity, the elucidation of the heart failure etiology, and the identification of arrhythmogenic substrates. So in conclusion, we currently the evaluation of cardiovascular disease in patients with autoimmune disease is based on the presence of cardiac symptoms and the identification of cardiac function changes, which are usually clinically overt in the late stages of the disease. CMR can provide cardiac tissue characterization and biventricular function assessment in the same examination, allowing for the early and accurate identification of important subclinical abnormalities before clinically overt cardiovascular disease. CMR tissue characterization by T1 mapping or T2 mapping and extracellular volume can provide reliable assessment of cardiovascular disease activity beyond blood biomarkers or facilitating early clinical consideration of appropriate immunomodulatory and cardioprotective therapies early and timely to the patients. The quality and extent of information provided by CMR may permit a personalized medicine approach to patients with these diseases, enabling better disease and patient-oriented choices of diagnostic, therapeutic, and monitoring strategies to prolong survival and enhance quality of life. And CMR protocols and diagnostic algorithms for its use, highlighting its role to start the precise and effective specific therapeutic approaches, timely and not when conventional imaging modalities and the clinical manifestations show the involvement of the cardiovascular system, impacting the outcome of these complex patients positively. Thank you very much for your attention.
Thank you very much, Dr. Sierra, for covering such a complex topic that I think even if you're a specialist in MRI, I think these topics have gotten so complex that we really need people that do imaging more in a disease-oriented manner, I think. Thank you, Dr. Garcia, for being here as well. If you would like to start with the first question.
That was a remarkable, comprehensive review, and I do agree with Leandro. I think it is so much that you bring to the table, not only by mastering the technique of magnetic resonance, but also your clinical experience and your clinical practice, which allows you to to think how to use EMR in a useful way. I just wanted to make one comment, and it's that you obviously didn't have time to cover absolutely everything. There is a whole new subset of problems that have been created iatrogenically now with drugs that actually can cause autoimmune problems, and checkpoint inhibitors, which are used for cancer, but they're also used for some of these conditions. Can cause myocarditis, and I think that CMR is actually key in many of them to evaluate, abnormal T1, T2 mapping, and to follow the evolution after treatment. And there is one question here I see in the chat from Helen Chansam, which is a good question. Can you differentiate by CMR the myocarditis that is caused by autoimmune conditions from those that are caused by a virus?
Well, that's something very difficult to respond. Usually the pattern of a viral myocarditis is more dramatic, there is more enhancement, and the myocarditis of these diseases is very tiny, patchy, can even be ignored if you don't read it carefully. So I think that's a key thing, but there is no way both could produce the same pattern.
Thank you very much. A question from Daniel Lorenzati that he has, congrats, excellent talk. Do you think there is a role for CMR, or perhaps PET CMR, in the visualization of coronary inflammation in vasculitis? Is it feasible with the current technology?
Yep, I think yes. I think totally possible.
So, and I think I'll go with another question. So it's very hard, I think, in particular in the US, to get approval for imaging in asymptomatic patients. Whatever type of imaging screening is something that is very, very hard to get approved. And obviously the insurance companies look at imaging for everyone, which would increase the cost a lot. So what kind of clinical trials do you think they need to be done, or what do you see from the CMR, and you're leading a world task on this? So what are the next steps to move the yield into lower risk asymptomatics to identify subclinical? What do you think is the future on that?
I think it's a great question, and I totally agree with that. We need to produce more information. So first, I was thinking in not just a clinical trial, but I think that we should use the CMR registry. the CMR registry has a lot of information there. So maybe the first step is to dig deep in that thousands of patients database and see if we could come up with something retrospectively. And if there's something there, then we can give some relevant data, and those patients has follow up, and recently the mortality data is included. So maybe we could have prognostic information based on that. And I think that would be the first step to say, hey, CMR is doing something, it's not just what I am seeing there. And the other thing is maybe to collect cases from all over the world and see how many of those cases have changed the diagnosis, as the cases I showed you. So maybe the original diagnosis is one, but after CMR, the diagnosis change. And with that change, you change everything, and even you save money, which is the important thing for the insurance company and the administrators, you know. So I think that those would be the first two steps I would recommend. In addition to follow this recommendation, the AICBI, and it is going to be, I think for the next year, the SCMR1. So we are going to have two position papers that supports these studies in this group of patients.
Thank you very much. Very important topic, and I learned a lot, and I'm sure everyone else did as well. So thank you. Keep the hard work, and we'll be looking for your publications.
Thank you.